Good afternoon, everyone, and welcome to today's COVID-19 update. We have Dr. Deena Hinshaw, Chief Medical Officer of Health for Alberta, and Dr. Werner Yu, CEO and President of Alberta Health Services. Dr. Hinshaw?
Thank you, Chris, and good afternoon, everyone. I would like to start today by explaining our process for identifying and reporting deaths due to COVID-19. Before I get to that, however, I first want to apologize to the family of the 14-year-old whose death I spoke about on Tuesday. The pain of losing a child is terrible enough without having that loss compounded by a public debate about the circumstances. I am sorry if the way that I spoke about that death made your grief worse. Since the start of this pandemic, I have heard from many Albertans, including those who have lost a loved one. I reflect often on the impact that our reporting, measures, and every other element of the pandemic response has on them. When I speak about cases and our reporting process, it is not to diminish the losses, whether caused by COVID or anything else. At the same time, we are in a global pandemic. We have an obligation to monitor and report deaths from COVID-19 infection and to be as timely and transparent as possible. In our reporting, we always include all deaths that have COVID as either a primary or secondary cause of death, according to the healthcare teams that were involved in the cases. For example, a primary cause would be someone in whom COVID infection progresses to pneumonia, and this is the direct cause of death. A secondary cause could be a case where someone with a severe underlying illness, such as heart failure, gets COVID, and the infection makes their pre-existing condition worse, leading to death. We report in this way to accurately capture the impact that COVID-19 is having. That is also why our reporting process includes both deaths that come to us where a person has COVID listed as a primary or secondary cause of death, as well as cases with a recent diagnosis of COVID where the cause of death is still under investigation. To make sure we are as accurate as possible, after a death is reported, if there is uncertainty, it is reviewed to validate our information. If that review identifies that COVID was not a primary or secondary cause of death, it is removed from our totals. Every surveillance system has to balance this tug-of-war between precision and timeliness. The more precise reporting is, the slower it is. We have chosen to focus on being as timely as possible in the interests of transparency. Sometimes, though, as in the case reported on Tuesday, the initial information provided to us changes after a review. While the initial report of the death of the 14-year-old included COVID as a secondary cause, we have now received additional information that indicates COVID was not a cause of death. As we routinely do with all similar reviews, when this happens, we remove the death from our reporting. This incident has caused suffering for many, and again, I apologize for this. We are making changes to prevent similar situations in the future. Going forward, we will not publicly report any COVID deaths in anyone under 18 until the review process has been completed. We will prioritize accuracy over timeliness in these cases. I want to assure everyone that these reviews are always done in cases of any uncertainty, so the overall COVID numbers we have been reporting are as accurate as possible. However, it is clear that we need a different process for young people, and we have put that in place now. Again, I offer my sympathies to everyone who has suffered loss from any cause. As I have said many times, every life matters and every death matters. Turning to today's numbers. Over the last 24 hours, we have identified 916 new cases of COVID-19 and completed about 12,700 tests. Our positivity rate was about 7.5%. There are currently active alerts or outbreaks in 342 schools. Of these, 8 schools are on outbreak. There are currently 1,016 people being treated for COVID-19 in hospital, including 231 in the ICU. Sadly, 30 new deaths were reported to Alberta Health over the last 24 hours. While these deaths occurred over multiple days from October 7th to October 13th, this is another tragically high total. As we have seen before, most of these deaths involve those who are not fully vaccinated. I want to assure Albertans that the vaccines remain highly effective. They offer great protection against the Delta variant and are the best way to help protect our most vulnerable. The high number of fatalities that we have seen recently are the result of rapid spread that occurred in this fourth wave. This is another reason why we all need to keep limiting in-person contact and driving cases downward. All of these people's lives mattered, and they will all be missed. My thoughts are with anyone who has lost a loved one, either to COVID-19 or any other cause during this pandemic. I would like to end today by talking about the coming influenza season and the importance of getting an annual shot. Every year, the arrival of cooler temperatures and shorter days signal the start of cold and flu season, and the same holds true this year. Our annual influenza campaign officially starts on Monday, and we'll be releasing more information tomorrow on how to book your appointment. While influenza and COVID-19 are very different illnesses, several of the symptoms are the same. Fortunately, similar prevention strategies, including good hygiene, such as washing hands, physical distancing, staying home when sick, and wearing masks, are effective in preventing the spread of both illnesses. We don't need to look further than the last influenza season for proof of that. Despite conducting about 2.5 times the number of influenza tests as we did the previous year, we had 0 lab-confirmed cases of seasonal influenza and no influenza deaths. This season, we have already had 3 lab-confirmed seasonal influenza cases. Influenza remains a serious and deadly virus, and it is important that we protect as many people as possible. Last year, we saw record-breaking uptake for the flu shot with more than 1.65 million doses administered. That was the highest uptake we've seen in over 10 years, but let's push for even better this year. Every Albertan over the age of 6 months can get an influenza vaccination free of charge. This year, many community pharmacies will be offering the flu vaccine, as well as some doctors' offices. For children under the age of 5 and their families, immunizations will be offered at public health clinics. To ease the system strain caused by increased demand for COVID-19 and influenza testing, I urge every eligible Albertan to get the COVID-19 and influenza vaccines as soon as you are able to. This will greatly reduce the number of people who get infected and the number of symptomatic people who need to be tested. We have heard questions about whether you can get your COVID-19 vaccine at the same time as your influenza vaccine, and the answer is yes. Scientific and medical reviews have determined it is safe to get both vaccines at the same time. So if you're eligible to get a COVID-19 dose, you can book your COVID-19 and influenza immunization appointments to take place at the same time. However, if you're not yet eligible for another dose of the COVID-19 vaccine, either a second shot or booster shot, you can get your influenza vaccine as soon as possible, and then book your COVID-19 immunization when you are eligible. By getting the annual influenza vaccine, you're helping to keep your family, friends, and neighbors healthy. You're protecting people at risk of severe illness, including seniors, pregnant women, and people with chronic medical conditions. And we're allowing hospitals to focus on treating the sickest people among us, including those with COVID-19. Thank you, and I'll now ask Dr. Yu to provide an update on the healthcare system.
Good afternoon. We continue to see pressures slowly easing on our hospitals, and in particular in our ICUs. This morning, our ICUs were at 76% occupancy, and we had 97 ICU spaces throughout the province available for new patients who require critical care. This is a significant improvement from just 1 month ago, when our ICUs were close to 90% occupancy, including the surge capacity, and the number of ICU patients was increasing rapidly each day. The number of COVID ICU patients being admitted every day across the province has reduced from more than 20 per day about a month ago to now about 13 to 15 per day. This is still a high number because these admissions are preventable. As I said on Tuesday, I'm cautiously optimistic. Our occupancy without the surge capacity of 203 beds is at 163%. This is better than the 172% I announced on Tuesday and 184% back on September 28th. And after experiencing perhaps the most difficult period in our healthcare system, we welcome good news. We are grateful that the numbers appear to be falling, but we know that this trend can be reversed easily, especially if we become complacent. And we remain uncertain as to the potential impact from the Thanksgiving long weekend. So while the pressure on our ICUs is easing, the workload of our frontline healthcare teams is still unprecedented. Our teams remain under constant strain, and I know that while the numbers look more positive, the pressures in the hospitals remains high. Improving numbers does not mean that the workload suddenly returns to normal. Their days continue to be extraordinary, and their efforts remain above and beyond what is usually expected of them. As I mentioned, without the additional ICU surge beds, our ICU capacity at 163% is well beyond what our healthcare system has experienced outside of this pandemic. So please, let's keep following the public health restrictions, get immunized if you haven't already, and stay home if you're feeling unwell. If we keep doing this, this positive trend should continue, and our healthcare teams can look forward to some respite because they all deserve that. Most importantly, this would mean that fewer Albertans are needing critical care and fewer families are being impacted by COVID-19, and it will mean that we can continue to slowly increase other healthcare services, including scheduled surgeries and procedures. Far too many Albertans have had their surgeries postponed over the past 6 weeks, and we know that this has had lasting impacts on those affected as well as on the healthcare system as a whole. A delayed surgery can mean a patient needing additional care and support in the longer term, further impacting their quality of life. We want to avoid that as much as possible, and that is why our surgical teams are carefully increasing the number of procedures as the capacity pressures eases. We do not have a timeline on when we can return to normal surgical volumes. That is still quite far down the road, but with each incremental increase, more Albertans are able to get the care that they need. Another way that we can all keep ourselves and our loved ones safe is by getting immunized against influenza. Generally, we see an increase in demand on our healthcare system at the start and throughout the influenza season, so we must all take steps to keep influenza rates down. As I've said, ICU hospital capacity remains tight, and a spike in influenza cases would be a concern. And as Dr. Hinshaw has said, getting immunized against influenza is easy. And the fact is we've all become attuned to the effectiveness of immunizations these past few months. The good news is that COVID-19 vaccines can be administered at the same time or at any time, either before or after other vaccines, including influenza. And since the COVID-19 vaccines have been available, there's been substantial data that has been now collected regarding the safety of COVID-19 vaccines. At this time, there are no specific safety concerns with administering both vaccines at the same time. I would like to finish once again by offering deep sympathies to all Albertans who are mourning the loss of loved ones, and apologies to anyone who's had their surgery or procedure delayed. The pandemic is like nothing we have ever experienced, and all of our lives have been impacted and changed since the first confirmed case 20 months ago. My hope is that we continue to work together to bring cases down, reduce transmission, ease the pressure on our health system, resume surgeries and procedures, and emerge from this incredibly difficult time. Thank you.
Thank you, Dr. Yu. We'll now go to question and answers. We've got one reporter here in the room at Edmonton and then some on the phone. So we'll start here in the room. Jeremy.
Hi, it's Jeremy Thompson with CTV Edmonton. A question for Dr. Hinshaw, actually. So Dr. Hinshaw, sort of throughout the pandemic, folks have been making claims that COVID numbers have been exaggerated, you know, saying someone comes in from a car crash and then they happen to have COVID, so that's chalked up to a COVID death. I guess and obviously that's incorrect, but I guess how concerned are you that this latest incident it could be used sort of to fuel those fires in those groups who are still circulating that misinformation?
We have had, over the past year and a half, different times where we have needed to adjust numbers. Sometimes that's because there's been a system issue and the flow of data has been interrupted. Sometimes, as people may recall, over the past, I've talked about having a certain number of deaths reported, but actually our overall number of deaths changed by a different number, again, because of some of this adjustment. So it has been my commitment and our commitment as a team to be as transparent with Albertans as possible. Certainly, some may make claims that there's information not being shared or that numbers are not accurate, and that's always a risk when we're transparent, because being transparent and timely means that we will need to make adjustments, because the information that comes to us initially sometimes does get adjusted over time. And we have always wanted to make sure that we provide Albertans with the most accurate and timely information as possible that we have at that moment in time. So what I would say is that that commitment remains the same as it has always been. We will continue to provide as timely as information as possible. We know that there's a higher degree of scrutiny that's required for individuals who pass away who are under the age of 18, as this case has clearly shown. And so for that particular group, we will apply that degree of scrutiny prior to reporting. And again, I want to reassure people that we apply that scrutiny to all cases. And ultimately, every single death matters. This is not about changing value placed on individual lives, but it is about reassuring Albertans that the numbers are taken very seriously and being very clear about where we're prioritizing timeliness, and the accuracy comes through later review, and where we're going to prioritize accuracy and reporting will come after the initial review.
Jeremy, do you have a follow-up?
I do. It's a bit of a morbid question, so I apologize in advance. But I'm wondering to what degree is ICU space opening up due to people dying as opposed to people recovering, and how is that factored into planning going forward?
It's an important question because, of course, a component of the change in the number of people in ICU is people who unfortunately pass away from COVID. Another component is, of course, those who improve and they're able to be moved to a regular hospital bed. But both of those things are a factor in how those numbers change every day. And what I would say is that we monitor that over time. Part of the predictions that are made in terms of the near term, what kind of pressures we anticipate on acute care based on what we have seen over the past several months, and if that played out going forward in a similar way, what we would expect to happen over the coming weeks. I want to reiterate, though, back to the basic message that we've been articulating for many, many months now, which is that all of these things have actions that we can take together to prevent them. So all of us who are eligible for immunization, stepping up for that protection, can not only prevent people from ending up in ICU in the first place, can also protect people, again, from having to experience that loss due to COVID. So again, ultimately, we do have ways that we can participate together in preventing those tragic outcomes, and would really urge people to both follow the public health measures that are currently in place, as well as accessing the protection that vaccines can offer.
Okay, we'll go to the phones now. Operator, can you put through the first caller, please?
Vernon, Global News. Hi, my question is for Dr. Yu. Dr. Yu, a group of firefighters and paramedics contract employees is launching or is threatening to launch a constitutional challenge to the vaccine requirement for all AHS employees. They say they would prefer to see the option of a rapid test be included, not just vaccination, but a rapid test. What do you make of this, and why was the policy developed as it is?
Yeah, I actually just received that letter today, so had a chance to take a look at it. It doesn't actually state specifically who they are representing. As you know, we don't employ firefighters. There are some contracted providers who have a combined firefighters EMS background that might be employed and may have to comply with the vaccination policy, but right now we just don't have any indication how relevant it is for Alberta Health Services.
Tom, do you have a follow-up?
I do, and it's on the broader policy here. Obviously, it's the end of the month that you need to be vaccinated by. Do you have a sense on what percentage of AHS employees are not vaccinated and will require further measures, whatever the next step is?
Yeah, we've been following the trends, and obviously every hour we're getting more submissions for our employees on their vaccination status. We are, one of the very important parts of the policy is actually being able to collect the data and to actually know exactly who's been immunized, who actually have some vaccine hesitancy, as well as questions, and who are overtly opposed to vaccinations. And this allows us to plan, it allows us to develop mitigations, and it also allows us to work proactively with our staff to make sure that they're informed about the decisions that they're making and to make sure that whatever decision they come up with, that it is evidence-based and that it is fully informed. So we're looking forward to collecting all of that data. The deadline is for Saturday for inputting the data, and we'll have more information available next week.
Operator, please put through the next caller.
Carly Robinson, City News.
Hi there, this is for Dr. Hinshaw. I just want to circle back to Jeremy's first question there. What do you say to the people who do believe that COVID numbers are being padded, that COVID death numbers are being padded by people who test positive and then get in a car crash, who test positive and then have an overdose? What do you say to those people?
To those who believe that the numbers are not accurate, I would say that the process that we follow takes very seriously the responsibility of ensuring that the deaths that we report do have COVID as either a primary or secondary cause. So if someone dies from a car crash or another cause that is clearly not COVID, they are removed from our deaths and they are not counted. So again, recognizing that it would be convenient to believe that COVID does not have the impact that it does. We've clearly seen that our COVID deaths track not only with the number of cases we have. So if our COVID deaths were being driven predominantly by deaths that happened from other causes where someone happened to be diagnosed with COVID, we would expect our deaths to exactly mirror our waves. And yet if you see our deaths that happened in our second wave, our third wave, and our fourth wave, they are dramatically different. We had very few deaths in our third wave, where we had significant protection. We weren't yet seeing the Delta variant and the impacts that has had. And so if it were true that our deaths are again mostly about chance diagnosis of COVID and then causes of death due to other causes, the ratios would be very similar. And in fact, they're not. Deaths in the third wave were low. Deaths in our second wave were the highest before we had vaccine available. And deaths in this fourth wave are in the middle of those two, which again shows that as we have a consistent reporting process over time, we are capturing those deaths that are due either primarily or secondarily to COVID.
Carly, do you have a follow-up?
Yes, thank you. I'm just wondering if you can give us an idea of how common a death being removed from the list is. Is there an estimation of how many times throughout the pandemic this has happened?
I've publicly reported it on some occasions in the past. Again, previously often it was because we had a certain number that were reported on a particular day, but some had been reclassified. There's also times where we've identified, due to chart reviews, that an individual who passed away that previously had not been coded as a COVID death is identified, and that is then added into our records. So I don't have an exact number. It's a relatively small percent of our overall reported cases, but it certainly happens as we move through this process. Again, usually relatively small numbers. If there's interest in having more precise numbers, certainly we could work with our analytics team to provide that. But the majority of cases do retain that initial classification after review, and it's a very small number that would be changed one way or the other.
Operator, please put through the next caller.
James Keller, Globe and Mail.
Hi, Dr. Hinshaw. I just have a question about schools. Can you explain the rationale for the rapid testing to be limited to schools in an outbreak situation, and are there plans to expand the rapid test program to all schools or more schools, or just to make it a bit more of a broader program?
There's a couple of reasons why focusing on those particular schools is the first rollout of the program. One is that we know that rapid tests are a little less accurate, so we know that false positives can occur. And we know that if you test a population that has no symptoms, where the prevalence of COVID is relatively low, you'll have more of those positive tests actually being false positives and causing some disruption that isn't necessary in people's lives. We know that the tests perform the best where there's a sort of a higher pre-test probability or a higher prevalence. And so focusing on those outbreak schools as the first place that we go to, first of all, is going to be the setting where those tests perform the best. And secondly, those are the settings where we already know that there have been potential exposures within that setting where they can do the most good by minimizing the chance that there is any further transmission within that location. And so as we move forward and evaluate that particular initial rollout, as we look to other jurisdictions who are using other populations, there's the potential for expanding to other school-age children, but we do want to focus, for the two reasons I've mentioned, on the initial rollout in schools that are in outbreak settings.
James, do you have a follow-up?
Yes, thanks. Just in terms of the threshold for kids in grade 6 and below, I think it's 3 cases within a 5-day period, and those classes can shift to remote learning. Why is it the threshold 3? I'm wondering, wouldn't 1 case or 2 case pose a risk of spread in classrooms?
What we've seen in schools, not just in Alberta, but in other jurisdictions, there's been some reports from other provinces that have looked at their own school experiences. And what we have seen is that it is relatively uncommon to have extremely large spreading events in a school from a single infectious person. So typically, with all of the other preventive measures that are in place, typically if there is an infectious person who's at school, there's either no transmission or a very small number. So having an entire school move to, or sorry, an entire classroom move to online learning when a single infectious person is present, again, is a low threshold that would likely cause more harm than good in terms of the disruption that that would cause for those individuals and families. If we look at the number, again, looking at whether it should be 2 or 3, we again know that when there is transmission, often it might just be between that individual who is infectious and maybe the person who they spend the most time with. If we have 3 infectious cases within 5 days, that threshold tells us that it's likely that there is something going on that's broader in that classroom, and moving that class to online learning is important at that point to minimize the chance of further ongoing transmission. But we do want to have a threshold that is high enough that we're not disrupting those kids, moving them without cause, but low enough that we're able to pick up something relatively early. And so when we looked at the options, it was our assessment that 3 and 5 days met both of those criteria.
Operator, please put through the next caller.
Kevin Nimick, CTV.
Hi, Dr. Hinshaw. Based on the information available to you, what do you believe was the biggest factor in the recent spike in first-dose vaccinations?
It's multifactorial. We know that many employers have moved forward with mandates requiring vaccine for their employees. That's likely a factor. We know that having the REP program so that people who want to access businesses and services that are participating in the REP, there's incentive for them to be vaccinated. We've heard that in some particular populations, there has been an impact of some of the incentive programs, so it's quite difficult to tease it all apart. When we look at how that's played out, again, I think that the major factor in terms of influencing people who are perhaps on the fence, maybe we're procrastinating, for them to go forward and take the protection that vaccine offers is for that to be something that makes their daily lives easier and smoother. And so things that really encourage people to take that step, again, things like the mandates that employers have been putting in, things like the REP, and then as the support for those who, again, may need a little extra incentive and for repayment. Sometimes the incentive program has been helpful as well.
Kevin, do you have a follow-up?
I do. I'm wondering if you can be a bit more specific about the $100 program, the incentive. You said that you believe it has led to more people getting vaccinated. What evidence do you have to reflect that?
So we have received reports in some particular populations where we're working kind of with our colleagues on the ground, where individuals, again, where resources are part of challenges that they face. We have heard that in some of those groups that the access to compensation has made a difference in their deliberations.
We have time for 2 more questions. Operator, can you put through the next caller, please?
Ashley Joanno, Post Media.
Hi, these are questions for Dr. Yu. I'm wondering what AHS's policy is for what counts as medical grounds for a vaccine exemption. When the mandate was first announced, AHS said that a policy document was being finalized. Is that going to be made public?
Yeah, so our teams have actually put a lot of effort into sort of looking at exemptions, and there are sort of 2 major grounds for exemptions. One is obviously medical exemptions, and the second area is in areas of human rights, such as religious reasons for exemptions. And yes, I think we actually can make those public for sure. They are based on evidence and best evidence. And so, for example, for the medical exemptions, it could be related to what we call anaphylaxis, which is a reaction to the vaccinations, or if they actually get a potential side effect from the vaccination itself. And so there are some clear indications as to what would be qualified under those different areas.
Ashley, do you have a follow-up?
Yeah. Can you tell me at this point how many people have applied for a medical or religious exemption? The Premier said yesterday that it was somewhere between 600 and 700, but I'm wondering what the actual number is and what will happen to those people if they don't have an answer from AHS by Saturday.
Yeah, so the number of exemptions that we've had so far is about 750 or so, and about half of them are based on medical exemption requests, and the other half is based on religious exemptions, and there's a very small number that is a combination of both. They are being reviewed through a special committee that we've pulled together with expertise to actually look at each of them individually. They do have to submit information in order for us to be able to review them, and that process is going to be done over the next few weeks. So it's not that they have to be completed by this Saturday. What I need completed by this Saturday is the information about the vaccination status.
Okay, we'll move to our last question now. Operator, can you put through the last caller?
Adrienne Williams, CBC.
Hi, my question is for Dr. Hinshaw. We've noticed that vaccination usually drops during the weekend, and we were wondering if you could explain to us maybe why that happens. Is it just like a lack of interest of people to get vaccinated during the weekend, or are there less spots available to get vaccinated during those days. So yeah, that's my question.
We have seen that vaccine, again, interest is something that does wax and wane. So I'm afraid I don't know specifically exactly all of the reasons why that is. But we have been working with immunization partners to make sure that there are opportunities for immunization on the weekend. When we had our fast flow clinics open, when the volumes of vaccines each day were very high and the demand was high enough to need those fast flow clinics, they were open 7 days a week. Many pharmacies offer appointments 7 days a week. However, there are some locations that would only be open on weekdays, so it's likely, as with many things, a combination. Potentially there are some alterations in availability, but also differences in interest when people might want to go out and get a vaccine.
Adrian, do you have a follow-up?
No, that's okay. Thank you.
Okay, well, that concludes today's press conference. Have a good day, everyone.